Good morning, everybody. My name is Professor Nick Sheezus. I teach in the psychology department. I want to thank you for spending your Thursday morning with us for today's program. The focus of today's panel discussion is going to be major depression. We'd like to start off by thanking Dr. Walter Franzik and the Liberal Arts Department for their support in bringing this program to campus every year. Thank you also to the entire psychology department for their support and ideas in making this a successful program every year as well. Everybody in the department helped us consider the topics that we were going to ask our panelists to present today, and a lot of professors have brought their classes too, so I want to thank you all for that very, very much. I'm grateful to our psychology club students and our Psych 101 students, Pam, Peter, David, thank you guys for helping usher our audience members. We got a bunch of open seats left, and finally, we want to thank our panelists. And I want to thank all you for being here, because we can't host events like this on campus without their help and without your help. So I'd like to give you all a round of applause, please. Two or three housekeeping items. Our program is going to take about an hour or so, 50 minutes for our panelists to speak, and then we're going to have about 15 minutes at the end for question and answers. We're going to grab the microphones on the side, come into the audience, and then direct our questions to our panel. And if there's any counselors in the room, please stop by the CEU table that's listed, stationed right outside of this room here to register for your 1-hour CEU certificate. For any students in the room, you're going to find a survey on your seat. And so if you're not going to fill it out, I will ask you to give it to the person sitting next to you. We would like to collect data so we could plan for future programs. So please fill these out. Hand them to any of us at the end of the program, because we want to be able to get a sense of what topics maybe to present in the future as well. So thank you for that. Finally, should anybody need assistance with depression, please make an appointment with our counseling center that's located on the second floor of the S building. I believe that we have several counselors in the room, so I'll just ask if they could raise their hands. So we have our counselors in the back, so please visit them and make an appointment. And also, our two representatives from NAMI have provided with a ton of literature in the back table, so please take some. Again, welcome to our annual mental health program. This is the 13th year that we've been hosting a program like this. We like to consider different topics of psychology and mental health every year. And as I said, this year we're going to be focusing on major depression, a very, very serious issue affecting our society and college campuses. According to the National Institute of Mental Health, 7% of adults in the United States have suffered from a major depressive episode in the past 12 months. Now, when you look at college students, the National College Health Assessment recently did a survey that indicated that 33% of college students have been impacted, their functioning has been impacted somehow due to depression. So I was looking at how many students come to Moraine. We have 9,000 full-time students, even more perhaps part-time students. But if you look at just full-time students of 9,000, that's potentially 3,000 students statistically that could be impacted by major depression. So we wanted to talk about that on campus and raise awareness for all that, which is why we've asked our panel of experts to educate us on the topic. So I'm going to ask our panelists to introduce themselves, and then, folks, we're going to get started. Who would like to start with their introduction? Just a quick who you are. So we'll take the microphone.
Hi, everybody. My name's Mary Ann Beethus, and I am president of NAMI South Suburbs. I'm a volunteer and an advocate. My daughter lives with schizophrenia, and she lives in recovery. So that's part of my story, and you can ask more questions when we get on. Thank you.
My name is Nick Sundberg. I work with Thresholds as a peer support, and I also do volunteer with NAMI. I am a person that lives with bipolar disorder, and I will talk more about that later.
I am Dr. Morris Blunt. I am a practicing psychiatrist in the Chicagoland area.
I'm Ron Zub. I'm an adjunct faculty here at Moraine Valley, plus owner and operator of a private practice in the suburbs for 20 years.
Awesome. Thank you again for being here, folks. Ron, I'd like to start with you. Again, we're happy to have you with us today and share some experiences and perspectives you've had as a therapist. What would you say are some treatment strategies that you might use as a therapist to help clients with depression?
Yes. First and foremost, if I could check in, are we able to hear well enough, folks? This is the first time that anyone's asked me to speak louder. Are we better? Are we good, folks? All right, a couple different things here, guys. A couple different goals that I have here for you today. We'll talk definitely about treatment options, but I think let's first start off with something very, very simple. and that is, what is depression? And I have a couple different very specific goals that I would like to, as I'm sitting up here, I would like to impose my beliefs upon you to some degree. First thing I'd like to do is educate you on what depression looks like on a daily basis. Two, I want to slightly motivate you to possibly pursue therapy if that's something that you need. And the last thing that I want to do is normalize what depression is. Way too many times people are dealing with depression, and unfortunately there is way too big of a stigma, and people are afraid. People are judged, and people do not seek help. So I'm going to tell you just a couple quick things. I'm going to give you guys, I know Doctor is going to probably discuss things from a very clinical perspective. But as I was thinking about presenting, I wanted to go ahead and come up with some of the simplest ways that I describe depression and how you could possibly identify it in yourself and someone else. One of the ways that I describe depression in the clients that I see is my client population that I work with, I would define them as the wounded well. Most of you in some way, shape, or form are aware and are able to function on a daily basis and function in life on a daily basis, but every single day that you're functioning, you don't function quite as easily, quite as happily, and with quite as much energy. And I think that is a very, very good way to describe what depression is. Depression is not always completely and utterly debilitating. Depression takes the joy out of life. Depression makes you feel alone in a crowded room. Depression makes you feel less than. And all these things are okay. So the first thing I'd like to let you know again, that depression I would describe as the wounded well. Most people that are dealing with depression are walking around. And this is not said in any sort of a silly way, but I know zombie movies are very popular right now. As somebody is just kind of walking around as a zombie throughout life. They're functioning, but they're functioning lost. They're functioning without much purpose. And one of the things that I would like to mention too, when you're dealing with depression, oftentimes people think that dealing in the field of psychology would be a profession that is a very, very sad profession. And I want to go ahead and talk to anyone here who's dealt with depression as this. I, as a therapist, think I have the best job in the entire world. Because I get to deal with people on a daily basis who have more strength, more courage, more heart than you could possibly even imagine. For someone to sit down, and yes, I do have a couch, it is true. For someone to sit down on my couch and have the strength and the courage to address their issues, to attempt to be better, takes more strength and more courage than you could possibly even imagine. My job is not depressing. My job is inspiring. My job is to make sure that people know that depression is normal. One of the other ways I would like to describe depression is this. I would like to call depression the silent suffering. Depression is something that people do not talk about. People keep it silent. People think that there's something quote unquote wrong with you. There's nothing wrong with you. You're dealing with a tough situation. The silent suffering. I describe depression as more days than not, your day is difficult. Depression, I want to be very clear, people, is not laziness. I'm going to give you a quick bit of advice. When someone's dealing with depression, don't tell them, just go outside. Just smile. I know it's going to sound very silly, but don't you think they've already thought of that? I said with tongue in cheek. I know everyone has the best intentions. But folks, the people that are depressed are suffering day in and day out. And you just got to think about this. The person next to you, the person at Starbucks with a great big giant smile on their face and who is likely hypercaffeinated, might be dealing with an immense amount of depression. And every single day, they have the strength and the courage to get themselves out of bed. But when they're alone at the end of the day, they feel empty, they feel worthless, they feel helpless. The clients that I see are the most powerful, most strong, most amazing people in the world. One of the last things I'd like to leave you with is this. Again, depression is an issue that deals with thinking. So one of Nick's questions was, what do we do to work with clients? We work with clients, we look to go ahead and see if we can reframe, reconceptualize, and for then any of you that have taken a Psych 101 course from a very cognitive behavioral perspective, change the way you think, change the way you feel, change the way you behave. That would be one of the core strategies that we use in order to go ahead and work with clients. Hopefully you can hear from my words that I'm saying here. I think therapy only works, however, and for those of you that have taken Psych 101 who understand a humanist perspective, counseling only works when you feel safe, secure, and not judged in the counseling process. So from a therapist perspective, my job is to make my clients feel safe and secure. Let them know that it's okay to be suffering. There is nothing wrong with you. The mere fact that you are sitting in front of me signifies that you have more strength than you can ever possibly believe. So right there, we implement the cognitive perspective, where immediately someone is walking in and they're feeling less than, they're feeling dejected, they're feeling alone. But if they can conceptualize themselves as this is taking a very strong first step in achieving mental health and positive mental health, that's what we're there for. One of the ways I think that I like to conceptualize a cognitive perspective is this. Depression is a war of the mind. I'm going to repeat that. Depression is a war of the mind. Every single day, you're well aware of what your negative beliefs are. You're well aware of the self-deprecating thoughts that you have. So my job as a therapist is to do this very simply. To win the war of life, you first need to win the war of your mind. Thank you.
Ron, thank you for what you do and sharing your thoughts and experiences with us. We'd like to ask Dr. Blount. Dr. Blount, thanks again for joining us today. If you could start us off by talking about a little bit from the psychiatric standpoint, what is depression, and perhaps how can we recognize symptoms in your experience?
Okay, a lot of what I think of as depression is very similar to what Nick mentioned. However, I see the wounded well as the severely wounded well. And when I say severely wounded well, these are the people who sometimes cannot make it to the therapist's office, who might need to be hospitalized because they are not functioning. They are not taking care of basic needs of what we call activities of daily living, showering, taking care of children, going to work, going to school. They are not functioning. These are the people who also might develop suicidal thoughts and might have plans to act on them. These are the people who need, in addition to therapy, oftentimes antidepressants or just pharmacotherapy in general, and or hospitalization in the most severe cases. I do like to think that therapists and psychiatrists work together. We do not work independently because treatment of depression oftentimes involves both realms. Now, being a psychiatrist, I shouldn't say this, but I will. Within the treatment, am the drug pusher, so to speak, all right? Meaning that I, having gone to medical school, have the biological training, and most of it I still remember, but I am prescribing medications to hopefully get people's chemicals, or more technically, neurotransmitters, back to where they should be in the brain. Generally, there are three main neurotransmitters or chemicals that we work with patients who have depressive symptoms. They are dopamine, norepinephrine, and serotonin. And most of the medications work on increasing or getting those chemicals back to the amount they should be within the brain. How do they work? Honestly, and don't tell too many people this, we don't know exactly how most of our medications work, believe it or not, but we do see the results. So if someone is prescribed a medication, or let me backtrack, medications are being studied and they can measure in more scientific places like the amount of serotonin and dopamine in certain parts of the brain. But how that medication actually does it, we're still not sure. Okay, generally, however, the medications do keep the numbers the way they should be. The best analogy I can think of now is, I think Nick said there were 240 people in here? Yeah. Or the common capacity?
Probably a little bit more, too.
So imagine that your brain needs 240 neurotransmitters, dopamine, norepinephrine, serotonin, floating around in the room, okay? All right. People who have depression might have 100 or 50. So the medications really help to keep those numbers up to 240. How they do that depends on the medication. Some medications, let's say, if somebody wanted to leave this panel discussion because they were bored, they would leave outside the door, right? Well, some of the medications would block those people from leaving to keep that number up to 240. Other medications make it so that when it's time to leave, that instead of having a double door, we'll just have a single door to get out. So, hey, the numbers will stay high. Some medications actually will open up an entire back wall so that 240 people can get in very quickly to make sure that the number of neurotransmitters in the brain is what it should be. So that's, in a very general sense, how the medications work, and it's what a large part of my practice is in prescribing.
Awesome. Dr. Blunt, thank you for that analogy, a really good way to describe it. We do have one more question for you. Is there any information that you could perhaps share about suicide? And I know not every depressed client or individual that lives with depression is at risk of suicide, but sometimes those things do coincide. Is there anything you could share with us?
Yes, first of all, we do have to remember that patients who do have a mental health diagnosis have a higher rate of suicidality than the general population. Do remember, however, that major depression is only one disorder in which suicidality occurs. It occurs in bipolar disorder. It occurs in patients who have schizophrenia. It occurs in patients who have personality disorders, as well as some patients who do have some medical illnesses. So depression is a factor in a lot of people who do have suicidal thoughts or who might attempt or commit suicide, but it's not the only illness. There are risk factors that we do consider in evaluating patients for suicide, and some of them are history of suicide attempts, family history of suicide, having a mental illness diagnosis, having a loss, major stressors, such as school, problems with family, lack of support. I actually find in practice, and having done this for nearly 2 decades, the combination of patients feeling isolated, feeling hopeless, and impulsive can be a deadly combination. Impulsivity, and I have to bring this in, impulsivity can be more natural in some people, and something else I find with patients who do attempt suicide, and is also a risk factor, is that substance abuse can be involved too. Especially alcohol, because alcohol, as we know, can disinhibit people. So if you are prone to be more impulsive and you have a and you're feeling down and hopeless and you're isolated and you have a substance that is going to make you less inhibited, you are going to be more likely to maybe even attempt suicide. So those of you, this is a college campus, so you have friends, you have colleagues, you know, you might wonder, what can I do, or what can be observed that where I can make a difference as a friend? Well, one thing I see in practice is people's changes in habits. You know, if you have somebody, a friend who's, unlike me, always on time for classes, or who likes to go and socialize, or I don't know what you guys do now, socializing, you might play on your phones or something, or they're not responding to you on the phone as much, that might be a clue that something is wrong. And that's the time to really intervene. It just could be, maybe they performed poorly on the test and they're not feeling good that day, but if that continues for days and weeks, then that should be addressed with that person. And it's very key to make sure that that person feels that he or she is not alone.
Yes.
Please.
If I may add one bit, really in conjunction to piggyback off of what Doctor had to say. Many people have very, very different and extremely strong beliefs for many, many different reasons on anyone who has ever attempted suicide. I would just challenge you guys all real quickly to think about it this way. If by chance you are aware or you've experienced someone around you who has attempted, I'm going to ask you to have a little bit of compassion. I can understand how you might have anger towards someone, especially if someone has possibly succeeded in the suicide process. I just want to put it this way very, very clearly for you. Someone who does commit suicide or attempt to commit suicide, there are times when it's an act of impulsivity, as Doctor had mentioned. But I want you to be very clear, and I want you to think about it this way. If by chance someone does end up attempting suicide, and they do end up succeeding, I want you to think about it this way. You could be really, really angry at the one attempt that they did succeed, or you could celebrate the fact that they were able to go ahead and fend off those suicidal thoughts and attempts for years upon years upon years. Most of the people that have thought about suicide have been contemplating it for years upon years upon years. So I think it's a much healthier perspective, and it takes away stigma, and it takes away judgment if we can celebrate the fact that they succeeded for years versus one time, and one time only, they just couldn't battle the demons.
And Ron, we may have somebody who's been living with a lot of pain for a long, long time as well.
Yes, suffering.
Absolutely. And the information you both shared it could be potentially life-saving for anybody in this room, and in general for anybody that watches our video, when we have it posted. And so, Ron, thank you.
Yes.
And Dr. Blunt, thank you. We're also fortunate to have Nick with us today to share his story. Nick, when you and I had spoken last month when we were organizing our panel, you shared with us that you have struggled with depression and you have received treatment and now are an advocate for mental health. Can you maybe share a bit about when you thought you needed help and maybe some of the coping strategies perhaps that you might use?
Well, I live with bipolar disorder, and I'm pretty sure a lot of you guys know what bipolar disorder is. One of the parts of bipolar is my depression, and my depression was so severe that there was times that I couldn't even get out of bed. I couldn't shower. The daily task of every daily task. Can you guys hear me in the back, or do I need to talk louder? Okay. So as I was saying, I can even remember that the depression was so bad that it was physically painful. I couldn't show emotion. I couldn't hug people because it hurt. And that caused me to isolate even more. When I was dating my ex-girlfriend, I couldn't show compassion. There was times that she wanted to be intimate and I couldn't do it. And there was times that I would force myself and I would resent her for it because I didn't know where it was coming from. And it hurt. It really didn't. Have you guys ever seen the movie Beautiful Mind, where she's in the bathroom and she just screams and breaks the glass? And I mean, that's what it was like. I couldn't be the person that I wanted to be for her. And some of the stigma that's behind that is that I would, my dad was a military kind of guy, and he would tell me, you just need to go cut the grass, or snap out of it, or be a man, stop being lazy. What are some of the other things? The stigma in school, that guy's just an asshole. Stay away from him. People would actually literally say that. I didn't have friends. My closest friends was my drug dealer, and the people I got high with, and that's how I coped with it. I did drugs, I did drinking, I would do dangerous things because there was times that I didn't feel anything. My counselor would say that I was detached. So I would do things where I would feel something, I would scare myself by doing, I would drive through red lights, I almost crashed my car many times. I would go to parties and someone would hand me a pill and I wouldn't even question what it was, I would just put it in my mouth. If someone did one line, I had to do 5 lines of coke. I was literally walking what my therapist would call dancing with suicide. My darkest times dealing with it was probably when I actually took my dad's gun and I was literally playing around with the chamber. And I was listening to the clicks of the gun, of the chamber spinning. And I learned now that people have to work themselves up to do it. And I remember I just had a moment of clarity. And I remember asking myself that if everybody is telling me that something's wrong with me, then something has to be true. Something that this has to be true. And at that moment, I told myself that I'm going to give in to this. I'm going to actually listen to the people around me, the people that love me and care about me. And because I would fight them. They was like, you need help, you need to go to the hospital, you need to be on medication. And my mind thought was, you're trying to fix me. You're trying to make me to be somebody that I'm not. And I would fight with them. And once I gave into that, once I actually accepted the fact that I was mentally ill and that I can actually do something about it, that was the part that gave me hope. So the stigma is unreal when it comes to that. And it also, the stigma that I would put on myself, and I still do it every day, because I still go through it. My bipolar is not going to go away. I'm going to live with this to the day I die. And there are days that I literally have to fight with myself. I have to question myself, can I get through this day? And the amazing thing that I found with my job, because I work for Thresholds, is that I actually have a boss that I can actually be honest with. I don't have to worry about being fired if I'm not doing well. There's even times I'll go to work and she will look at me, she's like, Nick, you're not doing well. Do you need to go home? And I actually can say yes. You have any idea what that feels like? Not being afraid of losing your job because of your mental illness? To actually be honest with the person that you're working with, that goes a long way. And I'm blessed to be able to be working with Thresholds and to be able to give back to my peers. I hope I'm not taking up too much time.
No, Nick, you're doing great. And again, I want to say, I want to interject. We're really glad you're all here. We're glad you're here. We're glad you're safe and able to give people a lot of hope. And again, thank you for sharing your insights. When we had spoken, you talked about how recovery isn't discussed enough.
Yeah.
Can you share a little bit about what recovery should look like?
Okay, so let me give you a little bit of backing of how I actually found out that I was living with bipolar disorder. And I'm going to leave the doctor's name out of it, out of respects to him. But let me describe this guy. This guy was really cocky. I'm not going to lie, he knew his stuff. All right, he knew exactly what he was talking about because once he looked at my CAT scan of my brain, he literally just named off things that I would do. And I never met this guy, and he knew me better than I knew myself, and that pissed me off. It did. And like, have you guys ever seen the TV show House? All right, that was him. All right, very arrogant. And it would piss me off because he was smart and he knew me. But he didn't discuss recovery enough. It was just, yep, this is the way your life is going to be. You're going to have to take this medication, and you might have side effects, and, well, you can't use drugs anymore. You have any idea how defeating that is? And I remember one time I actually told him, I was like, I trust my drug dealer better than I trust you, because at least when he says he has good stuff, he means it. And, I mean, he literally threw me out of his office. So, I mean, but that was the reality. That was my mind. Because you got to think about it. I never met a drug addict that wakes up one morning and says, yes, this is a good idea. I want to be a drug addict today. It doesn't work that way. I never met a drug addict that wanted to be a drug addict. There's an underlying reason why people use drugs, drinking, they get addicted to sex, whatever it is. I even got addicted to things that would, just doing reckless things. Now I actually am trying to do more positive things like skydiving because I need that. That's a part of my bipolar. There are times I need to feel alive, but I need to do it in a more responsible manner. So I'm even thinking about getting a motorcycle and stuff like that because I need that. And it stops me from using the drugs, the things I used to get from them. And I really want to touch base on that. When I would get high, it was maybe 30 minutes to an hour of just pure bliss. I don't have to feel pain. I didn't have to worry about the responsibilities I had of being a son or being a brother or being a boyfriend or worrying about my job. And there was even times that I couldn't even manage this being alive. And in some ways, that drug that I would do would actually keep me alive for that day. And then you had a doctor telling me that they're going to take that away from me. That's very defeating. So it wasn't until I worked with a different doctor that they actually used harm reduction. And harm reduction is basically not taking that life thing, that like whatever it is. I mean, I know drugs are bad. I'm not condoning it. But that was the only thing I had to keep me alive at that time. And she worked with me by gradually stepping down from the drug. And long as I was honest with her and she was honest with me, we built that relationship. And she said, you just need to be honest with me. You need to be honest with me what drugs you're taking, how much you're taking of, and if you're taking your medication, because she was trying to find a medication that would work with it. And I had to be honest with it because if there was a very severe effect, she needed to know. And she'd always talk about recovery. She was always telling me, things can get better. Things will get better. You just have to work at it. It's not going to be given to you. And that's what I do every day. I do that. Yeah.
Nick, thank you again. We appreciate it. Your insights, your experience, and we're lucky enough to have Mary Ann Bethos with us as well, who comes to us on behalf of NAMI, the National Alliance of the Mentally Ill. Mary Ann's president of NAMI. And Mary Ann, could you share a little bit about your struggle, perhaps, with depression, maybe how you received help before we talk about NAMI?
Actually, I live with depression, and it's a mild form of depression. I'm trying not taking away from people that have more forms of it. But I started out going just to my general practitioner and telling him how I was feeling, and then he would refer me to a psychiatrist and a therapist. I want to say over the last maybe 20 years, I have gone to therapy, I have taken medication. I take it for so long, and then I feel like it's not really working, so then I stop. And I think people are familiar with that. When you take medication, you either don't like the side effects, or you feel, oh, I feel better, so I don't need to take it anymore. I'm very fortunate not to have to take any medication anymore. I do have Valium that I will take occasionally if I'm, a little hyper, or if I'm getting a little anxiety. My husband passed away 2 years ago, and I found when he first passed away, I don't know if everybody feels this way, but it's kind of like you just go along and things it's a new normal, I guess you could say. And so basically I went on and everything was fine, and just the last maybe 3 months ago, it hit me. He's gone, and to deal with that is it's like, I mean, I'm a social person. I go out and I go to a lot of meetings, and I learn about as much as I can about mental health. I try to be there for my daughter who lives with schizophrenia. I worry about her because, she's functioning, she's working, she teaches mental health first aid in the community. So basically, but I still worry about all those triggers that she has that may, she may not be having a good day. I end up at the day, how was your day today? So a lot of things to worry about. So you have to learn when you live with your own illness that you have to learn to step back and take care of yourself, okay? And I think that maybe having a good therapist to speak to, which I go and see her maybe monthly now, maybe not every week or every other week. So having that person that that you can go to speak to about things that may be bothering you, you may not want to bother anybody else with it. You have to learn to monitor yourself on what it is you need to do to take care of yourself.
Thank you very much. Your experience in helping people with depression through NAMI, what has that been like for you?
Okay, I actually man our phone. NAMI has a phone number, 708-335-4008, and we have a website, NAMISouthSuburbsOfChicago.org, and we have a Facebook page. So basically, I man the phones, and I get phone calls from families every day. My family member is depressed or has schizophrenia, bipolar. What is my next step? I'm there to offer free educational programs for family members to learn about mental illness. I try to tell them my story of success with my daughter's recovery so they know that there's hope. And basically, I do get consumers, that's the person that lives with mental illness, calling me about their struggles, and I try to encourage them to, are you seeing your therapist? Are you taking your medication? People ask me, how can you do this every day? And I say to them, how can you not do it? When people need help and they're reaching out to you for help, somebody needs to be there to give them that information, to give them that hope. And I'm hoping that that's what I'm doing.
Excellent, thank you. Mary Ann, again, I'm glad that you're here and that we have you and NAMI to serve our community. If somebody wanted to connect with NAMI, what services perhaps could they offer?
Okay, we don't actually offer services, we actually offer education, okay? We have a family-to-family class that goes for 12 weeks. We do it twice a week for 6 weeks also. And at that family-to-family class, it saved my life, okay? If I hadn't taken that class, the second class talks about suicide. I went home that night and my daughter said to me, if Jennifer Lopez mixed bleach and kitchen cleanser together and drank it, would she die? And I my first reaction was, well, why would Jennifer Lopez do something like that? Well, I went to bed and I couldn't sleep, and in that class I learned that on the next day I could go to the mental health court that was on the Tinley Park Mental Health Hospital grounds, which is no longer there. I went in front of a judge and I got an involuntary commitment and had her put in the hospital. I know that she was very mad at me, and she told me the next day. She had been going to a provider for services to help with her mental illness, but she would not take the medication. And that next day, after she was admitted to Tinley Park Mental Health Hospital, she said to me, I realized that there must be really something wrong with me for you to put me in the hospital. And she took the medication the next morning. So she was on her road to recovery. So there is hope, there is recovery. We have a basics class that helps younger families with children from 14 and under learn about mental health and what you need to do to help that person that's living with the illness. We have support groups that, everything we offer is free. Support groups for family members and for the person that lives with the mental illness.
And our information is in the back?
Yes, my information is in the back table, and if you'd like to speak to me afterwards, that's fine too. Go ahead.
Well, the only other thing that we have is what advice, perhaps, would you give to anybody in our audience or people or family members that are recovering from depression?
You have to be as empathetic as you possibly can. Put yourself in their shoes. People don't ask to be mentally ill, okay? Just like people don't ask to have cancer or heart disease or diabetes. There is no difference. You have to remember, stigmatizing mental illness for all these many years, centuries, how far back you can go is inhumane. People living with mental illness are people just like anybody else. And being compassionate to somebody that's having a bad day, it's not hard to say, is there something I can help you with? Can I get you a cup of coffee? Would you like to talk about something? You know, learning those coping skills of how to deal with everyday life is very important. If you go to a therapist or a psychiatrist and you don't feel you're getting the answers, it's all right to say, I need to find a new therapist or a new psychiatrist. There's nothing wrong with that. You need to find a therapist that wants to talk about recovery, that wants to help you. Of course, they're going to listen to what you know, oh, I'm having depressive thoughts, I'm thinking about suicide. Yes, they do need to hear that, but they also have to have a plan. What is our plan? What is our next step? I do realize that you're going through this, but how do you think I can help you, and how do you think you can help yourself? You have to remember that family members need support. They need their family and friends behind them, not to criticize them, but to be there for them every step of the way.
Awesome. Marianne, thank you very, very much for your insights and information. I'm wondering, is there anything else from any of the panelists that our audience should perhaps know about depression? Anything that we missed? Nick?
Yeah, actually, take this. I do want to touch a little bit more on the stigma behind it, and I'm actually going to tell you a little bit of a story that actually happened with me. I kind of left this out, but it's actually important. One of the ways that I deal with stigma is humor. I can tell you a story. When I was actually in college, I went to the Institute of Art in Tinley Park. It's a very small college. It's 2 floors. You got 1 elevator, which is like the slowest elevator in the world. I had a speech class, and I did my speech on mental illness, and I ended up telling a class of 30 that I live with bipolar disorder. And I remember being in the elevator, and one of the kids that was actually in the class, he looked at me and he was kind of figuring, should I go in, should I wait, then should I take the stairs? Well, he finally came in, and he was always on the other side of the elevator, and he would keep looking at me, then look down, then look at me, and then he finally got enough courage to ask. He's like, are you really crazy? And I looked at him, I'm like, yes, don't piss me off.
Oh, boy.
And then the doors open up and he runs out. All right, so I deal with humor, and it wasn't until a couple weeks later that I would run into him once in a while, and then he started, saying hi, and then he started talking, and then soon enough he was starting to ask questions. And once I started giving him answers, the fear started going away. And he started opening up even more. And then it got to the point that he'd be just like, oh, hey, Nick, how you doing? And it was no big deal. So that's kind of the way I deal with stigma. It's the knowledge, you gotta have humor. Humor has saved my life, to be able to laugh about things. It's that's just the way I deal with it. So yeah, that's pretty much what I got. Anybody else?
I wanted to reiterate, just want to throw out a few terms that my colleagues here have mentioned. Coping skills, recovery, treatment plan, therapy, harm reduction. How many of those usually involve medication? What percentage? So my point is, yes, medication is an important part of treatment, but it is not the only part. And oftentimes, with a diagnosis such as depression, the percentage is much lower than the other treatment modalities. And I wanted to emphasize this because nothing against the younger generation, but I do find as time goes on, more people want a quick and instant fix, which might not be totally appropriate.
Would it be a problem if I add on to that?
Please. Yeah.
I can second say that. The medication is great. I do take medication for my bipolar and depression, but that's just one part of it. That just helps me take off the edge where I can actually focus clearly. The other part is up to me. So the things that I need to do every day is make sure I get enough sleep, make sure I take my medication, make sure that I'm exercising. I do self-check-ins. I ask myself, how am I doing today? Did I do all the necessary things I need to do to be able to be well? And then from there, I just, and then when I'm not doing good, the most important thing I need to do is be honest with myself. Not be afraid of, I'm having a bipolar episode and start freaking out about it. No, I need to step up and figure out what I'm going to do. So yeah, I definitely agree with.
The other thing, too, I wanted to bring up was that, one, proof that depression is biological is that people oftentimes do not have a so-called reason to be depressed. I'm sure you hear this sometimes. This person has a good job, has a 4.0 GPA. What do they have to be depressed about? Well, those people in those situations can still have depression, okay? Oh, by the way, Nick, you should have told that guy in school that patients with bipolar disorder are the brightest and most creative people on the planet. Okay?
Thank you.
Really.
Let's give our panelists a big round of applause. Sharing their amazing perspectives and information. At this point, I think I'm going to open up the program to questions from our audience. I think one of my colleagues is attending to something outside. I'm wondering if another colleague can perhaps grab one of the other microphones on this side of the room. And so we're going to try. We've got about a half hour, so I'm going to try to get to most of the questions that you may have. So if you have a question, just please raise your hand. I'll come to you. I'll give you the mic, ask the question, then we'll move on to the next student. Do we have anybody that would like a question, to direct a question to our panel? Okay, we'll start with you, ma'am, and then we'll start with you next. Nice and loud.
Yes, nice and loud. I got a big mouth. I'd like to hear from Nick if he could speak more about the manic side of his bipolar and what that looks like.
Oh, okay, all right. So the manic size, God. Let's see. So the two sides that I really had with my bipolar is severely depression and rage. I never really got the part where I felt like I was on top of the earth and that I can do anything. I never got that. It was mostly I was severely depressed, or I was just severely enraged. And I was to the point where if somebody just looked at me wrong, I was ready to fight. That was pretty much what it was. I remember one time I was actually at home and I literally busted all the mirrors in my house because I didn't like what was looking back at me. Was that logical? No. And when it came to the bipolar, I would also get really paranoid. My thought process was not right. There was even when I was dating my girlfriend, there was a period where I actually thought her and her mom was actually going to try to kill me because I was watching the TV show Snapped, and my mind was running with it. So that was part of the bipolar too. Also, I had no limit to things. When one person did 1 line of coke, I had to do 5 lines of coke. I always had to top the person next to me. I had, when we talk about emotions, there is no limit to emotions. And bipolar just amplifies it even more. There's no shut-off switch. I can't stop it. I can't turn it off. I can't slow it down. Another part of it is erasing thoughts. I could literally think about something that happened 10 years ago and be just as angry today as I was then. So getting over things is very hard. I literally obsess about things. So that's kind of the manic side of bipolar for me. I would also empty out my bank account a lot too. So.
One question here, and then we're going to take yours. Where is it? I'll tell you what, why don't we start with you?
Okay, thanks. Hi, thank you so much for this. I'm an instructor and I teach medical terminology and phlebotomy, and my students are with me because I think everyone who works in healthcare needs to know more about this. I think I have more a comment than a question because awareness and education is everything. But through personal experience with my mother and my son, law enforcement is a mess. Access to inpatient care is a mess. Then they're discharged after 3 days, and there's no psychiatrist to treat them, or it takes 6 months to get in. And if you don't have insurance, you're really messed up. And while my son was an adolescent, the southwest suburbs have like 0 adolescent units. At least that was 5 years ago. So we would spend all night in the ER with a raging sick person who was treated like a criminal, and then be bussed around the city to whatever facility would take him. So I know you don't have any magic answers. My question for you, because we know that you love your job because it's hopeful in that, is right now my energy goes to advocacy for that mess. Because unless something happens, there will be more suicides. There will be the police that are not trained in crisis intervention, and tragedies happen because they don't understand that someone's in a crisis. So thanks for listening, because I don't have a question.
Thank you.
Okay, but and I'm glad that you said that you're being an advocate now, because that's what we need. And I'm encouraging all you students, okay, if you're taking a psych course, please consider having a voice, helping your community, volunteering. We're trying to build our volunteers for NAMI, and I'd like suggestions and things you think maybe we could do to help. Of course, there is advocacy for legislation. I gave Nick some information. I just attended a seminar at the University of Illinois Chicago campus, and the young people are up and saying, we no longer want to be turned away. We want services. So you have to get involved with that legislation. You have to talk to your senators and representatives. We need more beds in the south suburbs. They took away Tinley Park Mental Health Hospital. And so we need advocates to say, yes, mothers should be marching on Washington just like Mothers Against Drunk Drivers. Our children are just as important as any other child living with any illness. Thank you.
I agree. I have seen a diminishing number of facilities that provide services. And gosh, one thing that I remember is when I first finished training, for patients who were at Tinley Park or at Madden Hospital, the state hospitals at the time, there were liaison teams, and Thresholds actually had quite a few of them, that had funding to cover every patient who was discharged for 3 months. So that patient did not have to worry about the cost of medication, the cost of seeing the doctor, any transportation costs or anything. Well, after a year or two of being in practice, guess what happened to that funding? It was cut. Yeah. So you have somebody, let's say, who's not totally convinced that he or she has a mental illness, who's been in the hospital the 3 days, as this lady said, who's being discharged and given an appointment 6 weeks out to see a psychiatrist. How likely is that person going to, show up for the appointment? We see it all the time. So advocacy, yes.
Could you speak a little bit about the danger of taking antidepressant medications or anti-bipolar or anti-anxiety medications without therapy or being properly monitored by a psychiatrist?
Great question. The danger really is subtherapeutic treatment. As we said earlier, the medication is a component, but it's not 100% of the treatment. So you're getting a partial response, partial treatment. Let's say that somebody was depressed and their coping skills in dealing with life stresses were not very good. Okay, I can give them, what medication do you want to give? Zoloft to them, and they might get better. Guess what? Something else stressful happens in life. They have no coping skills. That might knock them back, so to speak, several steps. So that's the danger, is that you're getting a partial treatment. It's like somebody having high blood pressure and bringing the blood pressure down a little bit, but still not within normal range.
Hello, my name is Linda Jones, and Nick was one of my teachers. And his colleague was also one of my other teachers, my psychology teachers. I brought a VA vet here, and he's also a retired psychologist, clinical. He's in clinical. So I would just like to say that the depression that people don't discuss as much with the VA and things like that, if someone could touch on it, his name is Mr. Collins.
Linda, can we maybe pose the question one more time?
If anyone knows or could speak on anything that the vets have about depression.
I see. Vet services, okay.
Yes.
VA services.
Oh, okay,
Yes.
all right. Regarding services themselves or certain diagnoses or?
What they go through.
Oh, okay. Oh, wow.
yeah.
Okay.
That's a whole topic in and of itself,
Yeah,
right?
number one.
Post-traumatic stress
Yeah.
disorder.
We do see it quite a bit. I think the biggest problem we have in this country, having grown up in a city in which there was a huge Army post, I grew up in Fayetteville, North Carolina, which is adjacent to Fort Bragg. We grew up to respect the military. And I was so shocked when I left that environment that outside of the military settings or settings in which the military has a great presence in the community, that people just don't respect the military. That still shocks me. You know, these men and women are going into harm's way, getting hurt, killed, severely damaged mentally and physically long term, and it seems that our society treats them as second-class citizens. I think that's the biggest problem. Regarding actual treatment, I do think the VA with the mental health is understaffed, as a lot of mental health is. I do think we should be steering more people to work in the VA. One thing I don't know if it's done for practitioners working in the VA or who want to work in the VA, but I know in certain communities, rural areas or urban areas, sometimes loans can be repaid if you work in those areas. So I don't know if that's happening for the VA hospitals or not to get more practitioners in there, but that kind of thing should be occurring if it is not. So I do think the veterans suffer from a stigma, in a sense, that society has about them being veterans, and just lack of resources. And again, we do need to address that segment of the population.
Yeah,
Can I add on to that? Sure. I also think the stigma also relies on that too, because they're military. They have this, because my dad's military, he never got help for his, whatever he was going through. I'm not a doctor, so I can't say what he had, but there was severely trauma in his life being in war. And his whole thing was he's Army, he's strong. He doesn't need to see a doctor. He doesn't need to go to the VA. That's the way he was. I couldn't tell him anything, So yeah, I think that's the stigma is also within the VA too.
Yeah, I think one of the last things here, there's two different issues. I know certain insurance companies like United Healthcare, specifically resources people who are experts in PTSD And I know that you can go to United Healthcare website and you can check that out. I'm not promoting them as a business, but I do know specifically that they do hire people who are well-versed. And as far as anyone dealing with VA issues, war issues, you want to make sure that you find someone who is highly, highly versed in PTSD. Just real quick, most people, when they think of PTSD, they think of someone who's having flashbacks. And if your therapist thinks that that's all that PTSD is, run. And that said with compassion and sincerity, PTSD is when someone is numb. When someone is able to tell an absolutely horrific story with no emotion, they have PTSD. So please make sure that whoever you reach out to is highly, highly, highly educated in what PTSD and trauma is.
Thank you, thank you. We have our next question here.
Hi, my name is Dino Wellborn. I wanted to speak about, or ask my question rather, about the no reason factor for people who have good jobs, are going to school and doing well, but they still have depression, and the shame that comes along with that because they feel that, you know, other people, they have traumatic events in their past and they have a reason to feel down, where other people, everything's looking up for them, yet they still feel isolated and empty. And kind of what other factors besides genetic lead to that?
Leading to them feeling that way are the thoughts they have, societal pressures, you know. Society says you shouldn't be depressed if you have certain things, you know, and they oftentimes do feel that there's something severely wrong with them, or that they are abnormal in a sense, and not a real person because I have A, B, C, D, but I still feel that way. So I do think, as my colleagues have been saying, if we get the word out about what mental illness is, what depression is, and that anybody can suffer from the symptoms, then I think there'll be less of that, what I call self-stigma.
And some people might have a biological predisposition in their family lineage to develop that.
Right, and even that, I see it all the time. I will, in doing a psychiatric evaluation, will hear that I have, you know, the patient will say, oh, I have an aunt who has depression, or, you know, uncle, mother, sister, brother. Then you ask about treatment. Well, she didn't really get treatment. Growing up, mom just kind of never did that much, and my older sister took care of us, and we made it. You know, I will hear that. But I'm thinking, oh, wow, if all these people in the family had it, there has to be a genetic predisposition. Or you might hear somebody say, well, yeah, it was present, but my mom never showed the signs. She was still able to get everything done. So why do I need treatment if my mother didn't need treatment? You know, some people don't get the support from their families to encourage them to stay in treatment. Oh, depression happens to everybody. Again, get over it, get over it. Just do what you need to do.
That mirrors what Ron said about the wounded well.
Yep.
Right, right.
If I may comment, sir, I think part of being a therapist is doing a good assessment. So we, according to what doctor was saying, yes, we would look to see if there is a biological predisposition. But, you know, I think sometimes people talk, you don't even realize what we're saying, meaning this. So if you grow up in a household where you tell your parents that you're depressed and they don't believe you or they minimize it, I would argue very effectively you have very good reason to be depressed because you're not allowed to feel. And I think that's enough within itself. That means likely someone might be growing up in an environment that is not as emotionally supportive, where you feel alone, where you feel less than, I mean, I know it sounds odd. Little kid's got a broken arm. Hey, I have a broken arm. Mom and dad are going to take it. Hey, I think I'm depressed. No, you're not. So again, I think, you know, your question almost answers itself. Growing up in a household where you're not allowed to be sad, it's a problem.
Yeah. Parents might even internalize that they did something wrong, you know, in the development process and that kind of thing. Nick?
Yeah, so it was actually a very good question. Even before I actually realized I was mentally ill and I was actually going through depression, I would actually ask myself, I don't come from a bad home. There's nothing really, you know, wrong in my life. I didn't really have a lot of trauma in my life until I actually got into drugs and drinking. But I remember at a very young age, I would question it, like, what is, you know? And then I remember another part to this is that I remember when I was actually on the streets after my parents kicked me out, I knew this homeless guy, and he had nothing to his name, but he was the most happiest guy I ever met. And I envied him. And So when we talk about depression, when we talk about happiness, it's not about where you come from or how much money you have or what you have in your life. It's, it comes from within. It really does. So.
Thank you. We have a question here, and then Maris, you have a question?
Nick, one quick, our Vietnam vet, he wants to say something really quickly.
Good afternoon, everyone. I'm Curtis Colin. I'm a retired Veterans Administration counselor. I'm a total and permanently disabled Vietnam veteran. I spent 6 months in the Hanoi Hilton with John McCain, my hero. I'm tired of people referring to us as crazy Vietnam veterans. It's disrespectful, and if you say it to the wrong person, you put yourself in jeopardy. Everyone suffers from emotional problems in some form or another at some times in their life. That's all I did at the VA hospital. I was a counselor. I still work with veterans at vet centers. I sympathize with those of you who have dealt with some of the things you've dealt with, because I have probably dealt with some of the same things. Do not be ashamed. You are not dealing with this by choice. And don't let anyone make you feel otherwise, because your positive attitude is a structural part of your recovery process. Thank you.
Hi, I just wondered if you would talk a little bit about meds and the difference between treating bipolar versus treating depression, and maybe some of the newer meds and side effects?
Wow, that's a loaded question. Okay, we have to remember that bipolar, by definition, means two poles. One pole is depression. The other pole is like the bi part, which is variable for people. Like Nick said, his is more anger, irritability. Some people are happy on top of the world. So the difference between the medication classes is that antidepressants are used to treat the depressive side to treat depression, whether it's in bipolar disorder or in major depressive disorder. Whereas the bipolar medications are used to treat both the depressive and hypomanic or manic side of the illness. Some of the treatments for bipolar disorder have some components that the antidepressants have in them, and some do not. Okay, various classes. I'll make this as brief as possible. We have one, probably the most popular class, what we call the selective serotonin reuptake inhibitors, which works on that chemical serotonin that I mentioned earlier when we first started. Those medications increase serotonin. All right. Then we have another class called the serotonin norepinephrine reuptake inhibitors, which help to boost serotonin and norepinephrine, two other chemicals. Then we have tricyclic antidepressants, which are older. These were more like Elavil, Tofranil, Doxepin, which has the other name, Sinequan, which work a little bit on serotonin, dopamine, and norepinephrine. We don't use them as much now, and we call them TCAs. Number one, because the onset of action is a little bit longer than some of the newer antidepressants, and unfortunately, they could be lethal in suicide attempts. With some of those medications, if you take an entire bottle, it slows your heart rate to the point that you might not get up again. So we don't use them as often. And back when they were using them, they were getting out of favor when I was ending training. Prescribers would prescribe maybe a week's worth at a time or 2 weeks worth at a time for that reason. Then you have, let's see, some of the other medications used for depression that boost dopamine and norepinephrine. What I'm thinking of offhand is Wellbutrin, or bupropion is the other name for it. Okay, that covers the major classes of the antidepressants. Oh, I did leave out one class, the monoamine oxidase inhibitor medications, which we don't use very much now, because with those medications, you can't drink red wine, you can't eat cheese, and that kind of thing. So it's really difficult to get patients to adhere to that kind of dietary restriction on the medication. All right, for the bipolar medications, there are a few classes also. Some were actually anticonvulsant or anti-seizure medications when they first came onto the market. Those would be Depakote, Tegretol, Trileptal, Lamotrigine, and actually they started being used for bipolar disorder because they found that patients who had seizures who also had the mood swings got improvement in the mood swings. We also use a class of medications called the atypical antipsychotics for bipolar disorder now. I probably use those more than the other ones. Right, I heard Abilify over here, that's one of them. Abilify, Latuda, Risperdal, Seroquel, Geodon, Saffras. They're very good medications. Side effect profile is fairly favorable. We do have to watch out for, in some of them, increased blood glucose levels, cholesterol, that kind of thing. However, the difficulty with those medications is getting patients beyond the name antipsychotic, because my patients who do have bipolar disorder especially will say, well, doctor, I don't have schizophrenia. Why are you giving me an antipsychotic? So I have to go into the whole spiel, but that's just the name of the class. Other treatments are for those are the main ones actually for bipolar disorder, but we also in psychiatry use a lot of adjunctive medication. Let's say if somebody's taking an SSRI such as Zoloft, that we might add a low dose of a medication like Abilify to it to boost the effectiveness. Some of my colleagues will use stimulants to help boost the effectiveness of medications. Years ago, they were actually using medications such as lithium, which is another mood stabilizer for bipolar disorder. So I think that should be enough right now. We could sit here and talk an hour or two about the medications, but yeah.
Okay, I just want to interject real quick, though, that anybody that's taking medication has to be their own doctor. Okay, you've got to learn those side effects, and you have to remember that what works for one person doesn't work for everyone. Okay, so just be cognizant of that.
And that's a very good point, because I will hear from patients, well, I don't want to take medication A because I had a friend who took it and she did not respond well. Just quickly to talk about side effects, you did ask me that question too, I didn't really get to it. With the tricyclics or the TCAs, drowsiness, dry mouth are very common. With the SSRIs, actually people can have some initial heightened anxiety when they first start them. And they can also cause some nausea, GI upset, some mild diarrhea for a few days. With the bipolar medications, the atypical antipsychotics can cause some drowsiness, and some of them can actually cause some feelings of feeling jittery. Those are the main things to look out for.
Thank you so much for being here. Like, I feel it's been I have two quick things. I really felt like it was a very awesome, talk to be able to talk about this and destigmatize it. And I really appreciated when you brought up the idea of how when someone's, having good grades and have good jobs, why would you have depression? That sinks you deeper, I feel, because it makes you feel like, oh, something must really be wrong with me if, all this stuff is going good and then I still feel this way. So I really appreciated that. And then my next question would be, talking about the dopamine, the serotonin, and the epinephrine, how do you go about prescribing? Do you wait a few sessions, see if you can do it without medicine, or how, just a normal setting? How would you give a patient, be like, okay, we're gonna try this time?
Okay, I'm smiling. That's another loaded question. How about that? Remember, as Marianne said, everybody's different. So how I prescribe, if I prescribe, how long I wait for the first follow-up is customized for every patient. If a patient is what I would say a mild worried well, oftentimes I don't prescribe. And in my work setting, patients will have to come in for orientation, then intake, and they've already seen a therapist for a few sessions before they actually see me. So I have a better sense in my work situation if the patient really needs medication. If the patient just feels that, oh my gosh, I'm taking care of my kids, but I don't get quite as much enjoyment out of it, or I'm having a rough time with my boss at work or something, but it's still functioning, oftentimes I'll say, you know what, you're kind of on the fence with whether you need medication or not, so I'm going to hold off for now, but continue to see your therapist. I'll see you in 4 to 6 weeks and reevaluate to see if we really need medication. If somebody's coming from the hospital and they've attempted suicide, and the medication is going to be continued, if not raised, you know? So if a patient is coming from a primary care doctor and has been started on a low dose of medication and they feel that, oh my gosh, I'm still not functioning, then, you know, I will raise it right away and maybe see them quickly. So it's a little bit difficult to answer your question because everybody's different. So as a prescriber, I really have to keep an open mind and not trying to put people into very narrow categories.
We have time for one last quick question, and then we're going to have an announcement from our counseling center.
Alrighty, so I wanted to touch base back on growing up in a family that might not be so open-minded to the idea of mental illness, because I mean, I personally, you know, was struggling with that with my own family, and there weren't a lot of resources for me as a minor. You know, like the only thing that I really had was my school counselor, and my sister wanted to get me into, you know, a place where I could actually speak with an actual like doctor, but unfortunately she wasn't able to sign me up because my mom didn't consent to it. So I just want to know what kind of services are out there for like people like minors that might not have the support from their parents or their family.
That's a very good question because a minor does have to have permission from his or her parent. If it's a severe situation and there's a practitioner, doctor, primary care doctor, sometimes the courts can be involved, but that's extremely difficult because the guardian, you know, makes the healthcare decisions for their children.
Go ahead, please.
I was going to say minors as well can get up to 5 sessions, usually without their parents' permission as well, usually through school or other resources.
Oh, that's great to know. Medications, forget about it.
I just think real quick, I don't know if all of you read the Southtown, but Lady Gaga actually has a nonprofit organization that she started, and she's awarded money to Stagg High School for the teenagers to go for mental health first aid for teens. So I really suggest if you are really interested, there is mental health first aid that is offered out in the community. Sertoma does it for free. There are providers that also offer it, like Grand Prairie Services, but they charge. So I actually, if you go to our Facebook page, NAMI South Suburbs of Chicago, we will be offering mental health first aid for youth in May and mental health for people 14 and older in June. And so if you'd like to sign up, we are offering it for free. NAMI's partnering with Sertoma, and my daughter will probably be teaching the class.
Okay. Hi, everyone. So my name is Shania Gray. I'm a counselor here in the Counseling and Career Development Center. We're upstairs in S202. All of our counselors on staff are licensed clinical professionals, and so some of them will be standing outside. If you have any further questions about depression or you want to learn a little bit more, we offer services free of charge for students here. They can come in and we can help them. We address issues such as personal counseling, depression, anxiety. We do counseling with you. So feel free to utilize our services, and if you need to speak to a counselor outside on the way out, we also have brochures for you. Thank you.
Thank you. From the size of our audience, this was a very important program. Let's thank our panelists one more time.